Welcome to the deep dive. If you're listening, you are probably getting ready for a case. Maybe trying to get your head around the literature for rounds or just trying to make sense of this really complex topic.
Exactly.
Today, we are taking a really intensive look at meniscal allograft transplantation, or, MA.
Right.
And we're going to try and move past the basic if you should do it and really focus on the how, and maybe more importantly, the long-term what if.
And I think we should frame this deep dive almost like a pre-op review for a complex case.
I like that.
We need to have clinical precision. We'll be using the language of biomechanics, surgical planning, because we really want to focus on those critical nuances that separate a successful outcome from a technical failure.
Because in this procedure, it's all about anatomy.
It is entirely predicated on anatomic reconstruction. And thankfully, the literature really does provide the blueprint for that.
I think we have to start with the historical context, though, because it's such a humbling reminder of how science evolves.
Oh, absolutely.
The meniscus, which, we now treat like it's orthopedic gold,
It is.
was once considered junk. I mean, literally, Sutton, way back in 1897, he just dismissed it, called it a vestigial remnant of leg muscle.
Remnant of a muscle, can you imagine?
Which said you could just take it out without a second thought. And for decades, total meniscectomy was that was the standard of care.
And that historical context is just so crucial. It really underscores this massive paradigm shift.
So what was the turning point? When did we stop thinking of it as just a remnant?
It was 1948, Fairbanks. That was the seminal report.
Ah, Fairbanks.
Right. He was the first to really connect the dots. He correlated the clinical deterioration after a total meniscectomy.
With what you could actually see on an x-ray.
Exactly. With specific observable radiographic changes. Things like that femoral notch ridge forming, the joint space just disappearing.
The classic signs. Joint space narrowing, flattening of the condyles.
He formalized it. He proved that taking out the meniscus leads directly to the cartilage just failing.
And that failure is the whole reason we're even talking about Matt today.
Of course.
Because even with the best repair techniques, sometimes a total or near total meniscectomy, it just happens.
Yeah.
And it leaves patients in a lot of pain and facing this really rapid march towards arthritis.
And these are asymptomatic patients.
And the demand is huge.
Yeah.
I mean, Vitanovich and his colleagues estimated that nearly 3,300 meniscal transplants were done just in that 4-year window between 2007 and 2011.
It's a huge number. So our mission today is to really analyze the evidence that supports MAT as a viable treatment for these meniscus-deficient patients.
Okay.
We have to unpack the precise biomechanical requirements. We need to contrast the different techniques for anatomic fixation, which is, I would argue, the most demanding part of this surgery.
Sure.
And then critically assess the long-term data. Is MAT a cure? Or is it just buying the patient a decade, maybe two, of high function before the arthritis just inevitably catches up? We need to know where the field stands right now.
All right, so let's start where every orthopedic case has to start. Anatomy. But maybe not the gross picture. Let's focus on the architecture, the microanatomy.
Good idea.
Because the meniscus is this remarkable fibrocartilaginous biphasic structure. It's not just a piece of gristle. It's a dynamic, hydrostatically protected machine.
I like to think of it less as a simple cushion and more like a shock-absorbing fire hose. It's made of a really specialized rope.
A fire hose, I like that. So the water pressure inside is what's pushing back.
Precisely. The bulk of it, a full 75%, is water. But that water retention, that's all governed by the solid phase, which is only about 20 to 25% of the total mass.
And that solid phase is overwhelmingly collagen.
90% type I collagen. That's what provides the critical tensile strength. It's the rope.
And the rest of that solid part is that charged matrix. That's the secret sauce for its viscoelasticity.
It is. The rest of the matrix is dominated by proteoglycans, and they're attached to these highly negatively charged glycosaminoglycans, or Gs. And because the GAGs are anionic, they repel each other, and they attract a tremendous amount of water. So when you compress the meniscus, that hydrostatic pressure forces water out, which dissipates energy.
And when the load is gone,
the GAGs immediately pull all that water right back in. This controlled fluid flow is what gives the meniscus its remarkable capacity for shock absorption and load distribution. It's a bioengineering marvel.
The real genius, though, is in the arrangement of those type I collagen fibers.
Yeah.
I mean, that orientation dictates everything function, and critically for us, how and where it fails.
Absolutely. The primary orientation is circumferential. so parallel to the periphery. This gives it incredible strength against tension.
And the radial fibers?
The radially oriented fibers, which are much fewer, they act like the stitching on a baseball. They're the ties that resist longitudinal splitting when the meniscal body gets loaded.
So if you imagine an axial load coming down through the femur, the wedge shape of the meniscus tries to push it outward, radially.
Correct, but because the anterior and posterior horns are so rigidly anchored to the tibial plateau, that attempted radial displacement gets converted into immense tensile strain.
Which generates the circumferential hoop stress.
That's the mechanism.
Yeah.
It's how it converts a compressive force into tensile resistance. It resists extrusion and effectively bears the load. The mechanical data on this is staggering. The meniscus is estimated to be 100 times stronger and stiffer circumferentially than it is radially.
100 times stronger. It's no wonder those radial tears, the ones that disrupt the hoop stress, are so catastrophic for the joint.
Exactly. It's like cutting the drawstring on a bag. Once you lose that circumferential resistance, the meniscus just extrudes and all that load collapses right back onto the articular cartilage.
And that's the failure.
That's the failure. One of the papers points out that the relatively low circumferential shear strength in the radial plane is believed to be the weak point that leads to those really challenging longitudinal tears we see so often.
Okay, so moving from the structural design to its biological maintenance.
Yeah.
Vascularity.
Huh.
It's a structure that kind of starves itself in the middle.
In adults, yes. We're relying on a very limited peripheral blood supply, the parameniscal capillary plexus, which comes off the genicular arteries.
But that blood supply doesn't penetrate very far.
It's minimal. Only 10 to 30% of the width of the medial meniscus and maybe 10 to 25% of the lateral meniscus gets any direct blood flow. The inner two-thirds is largely avascular, the white zone.
Which means?
It means nutrition relies entirely on diffusion and the mechanical pumping action of joint movement. This is the biological reason why meniscal repair outcomes are so fiercely dependent on the zone of injury. A tear in the red zone heals because it has blood. A tear in the white zone, it's a much bigger challenge.
Let's hit the load-bearing numbers now, because this is the real why for transplantation. The difference between the medial and lateral compartments is it's huge.
They behave completely differently. The medial meniscus is a broader C shape. It's tethered much more rigidly, and it transmits roughly 50% of the load in the medial compartment.
And the lateral side.
The lateral meniscus is nearly circular, it's significantly more mobile, and it transmits a whopping 70% of the lateral compartment load.
Wow. Why does the lateral side carry such a disproportionate load?
It's mobility. It allows it to travel more effectively with the lateral femoral condyle during motion. This makes it a superior stabilizer and load sharer.
And that load sharing gets even more intense with flexion.
Dramatically so. We see the numbers climbing to 85% of the total joint load at 90 degrees of flexion. It's not a static washer, it's a dynamic trampoline.
And when you lose that trampoline,
yeah,
the consequences are immediate.
Catastrophic. The numbers are sobering. A total medial meniscectomy leads to a 100% increase in contact force on the cartilage. So double the normal stress.
Okay, double is bad.
But a total lateral meniscectomy leads to a 200 to 300% increase in contact force. It's not just double, it's triple the pressure spike. This massive difference is what dictates our clinical urgency. If I see a meniscus-deficient knee, I am much more worried about the lateral side first, because that cartilage is facing an immediate, insurmountable mechanical overload.
So we've established the structural failure. Let's look at the natural history now of a knee that's missing this primary load distributor. And this data isn't new, right? This has been validated for decades.
Decades. The work by Cox and his colleagues in canine models really established the core principle. The amount of degenerative change is directly proportional to the amount of fibrocartilage you resect.
Simple as that.
You take out a quarter, you get some wear. You take out the whole thing, you get severe, rapid arthritis.
And McGinty's human data showed the exact same thing. He compared outcomes between patients who had partial versus total meniscectomies.
And the results were stark. The total meniscectomy patients showed early radiographic degenerative changes in 62% of cases. For partial meniscectomy, only 36%.
It's just proof that preserving as much of that hoop stress mechanism as you can is paramount. You have to maintain the contact area.
And when you lose the structure entirely, the geometry just collapses. That's what you called the biomechanical disaster.
It really is.
It is. The loss of that wedge dramatically decreases the joint contact area. We see reductions of 50 to 70% medially, 40 to 50% laterally. Imagine trying to support a football player's weight on the surface area of a golf ball.
The stress concentration would be enormous.
Exactly. And that concentration of stress, especially with that higher initial peak on the lateral side, is why degenerative arthritis just moves so much faster in that compartment. We're moving from a physiologic range of stress tolerance to a destructive supraphysiologic range.
Okay, so the rationale for MAT is clear. You have to restore the contact area to protect the cartilage. But why an allograft? Why isn't this tissue highly immunogenic, like, say, a kidney or a heart?
This is one of the great biological freebies we get with meniscal tissue. It's relatively hypocellular, and the primary functional part is the extracellular collagen matrix, which is acellular, so it just elicits a minimal immune response.
Minimal.
Clinical reports estimate symptomatic immune reactions in only about 1.3% of transplants. It's incredibly low.
And some of the models even suggest that fresh tissue is safe.
Yeah, Ochi and colleagues, they used a mouse model and looked specifically at fresh meniscus and found no evidence of immunogenicity over a 24-week period. It's likely because the cells are mostly chondrocytes and fibroblasts-like cells, which just aren't highly antigenic.
But the tissue banks, they freeze or deep freeze these grafts. That can damage the cells. Don't we still find some residual antigens on the non-collagenous parts?
We do. Rodeo's group specifically identified class I and II HLAs, particularly on the endothelial cells in that peripheral capillary plexus and some of the synovial lining cells. But, and this is the critical finding, even with those antigens present on frozen allografts, they found no evidence of frank immunologic rejection that negatively correlated with the patient's clinical outcome.
So the immune system might notice it's there, but it doesn't really mount a destructive attack.
Exactly. It seems to tolerate it, which really emphasizes that the core function here is structural, not cellular. The meniscus allograft is, for all intents and purposes, a passive scaffold.
A scaffold.
Precisely. Donor cell viability is completely secondary to the integrity of that scaffold. Studies by Jackson and DeBeer on cryopreserved grafts showed a rapid and almost complete turnover of the donor cells.
So the host's own cells move in.
Within 1 year, up to 95% of the cells are replaced by host cells, migrating in from the synovium. It's a complete cellular remodeling.
So the host body is basically using the donor's collagen structure as a template. That sounds pretty ideal, but you mentioned this remodeling has an inherent risk. What's the failure mode?
The failure mode is a loss of structural integrity. While the host cells repopulate the scaffold from the periphery inward, the central core often remains acellular. That's biologically concerning given the high load it has to bear.
Right.
But more importantly, studies have shown that during this repopulation process, there's a distinct loss of that crucial circumferential collagen orientation, especially in the superficial layer of the meniscus.
Wait, if the superficial layer loses that precise circumferential alignment, doesn't that make the graft inherently weaker against hoop stress?
It does. The superficial tangential layer is critical for resisting friction and distributing stress. If the new host cells fail to reproduce that organized orientation, the remodeled allograft is mechanically compromised. It's just more susceptible to tearing down the line, especially with high-demand activities.
So that's the trade-off.
That's the biological trade-off we accept with the MAT. We get low immunogenicity, but we inherit a long-term durability risk because of this imperfect remodeling process.
Okay, so if the structure is everything, then graft preparation and preservation are they're non-negotiable quality control steps. Before this tissue gets anywhere near a knee, we are completely reliant on the tissue banks.
100% reliant on their stringent protocols. And it all starts with disease transmission prevention, aggressive donor screening, quarantine, comprehensive testing for HIV, hepatitis B and C, syphilis, the whole panel.
And the procurement is time sensitive.
Very, within 12 hours for fresh grafts, or 24 if it starts at 4 degrees Celsius.
And then there are processing steps people might not think about, like debridement and washing.
Yes, and each one has a specific purpose. Debridement removes the peripheral synovial tissue, which is the most cellular and potentially antigenic part. Pulsatile washing mechanically removes residual blood and cellular debris.
And the ethanol treatment.
That's a key chemical step. It denatures proteins, which further reduces antigenicity and any potential viral load, but it does it without significantly disrupting that type I collagen matrix we absolutely need to maintain.
The big leap in safety, though, especially for viruses, was the introduction of direct nucleic acid testing, the PCR assay.
Oh, that was a game changer. It's been widely used since about 2005. The problem with the older antibody tests was the window period. the time between infection and when the body makes detectable antibodies. That could be 4 to 6 weeks.
And with PCR.
PCR detects the viral DNA or RNA itself, so it shrinks that critical detection window down to about 10 days. Even with all these protocols, we still counsel patients on the risks, but the numbers are incredibly favorable. The estimated risk of HIV transmission from one of these grafts is about 1 in 8 million.
That's incredibly safe. So let's look at preservation. Table 40.1 in the source material summarizes the 4 main methods, but really only a couple of them are viable for routine use.
Right. Fresh grafts are technically the best because you maintain cell viability and there's no freezing damage. But the logistics are a nightmare. You've only got about 7 days to do all the serology, the sizing, the scheduling. It's just impractical.
Then you have cryopreservation. Arnowski's study showed this maintains the material properties remarkably well.
It does. Cryopreservation uses a controlled, very slow freezing process, which reduces ice crystal formation and damage. But it's technically demanding, it's expensive, and the cell viability is still all over the place, maybe 5 to 54%. Its complexity really limits its use.
Which brings us to the one we see most often, the clinical favorite. Fresh frozen or deep frozen?
Deep freezing is the workhorse. It offers the best balance of safety, cost, and structural preservation. It's a simpler process, it's cheaper, and critically, the deep freeze kills any remaining viable cells and significantly denatures those histocompatibility antigens.
And it holds up over time.
Milikowski and his colleagues provided the data showing good structural preservation at 48 weeks. It's the most favorable method we have right now.
And the one method that's universally rejected, freeze-dried or lyophilization.
Avoid it at all costs. The studies are definitive on this. Milikowski's initial work showed that 9 out of 10 lyophilized grafts just shrank. Wirth later confirmed this shrinkage and architectural disarray in long-term reviews.
Why does it fail so badly?
When you remove the water through lyophilization, you compromise the critical structural integrity of the collagen matrix. You're left with a shriveled, distorted piece of tissue that just cannot bear load correctly. It's useless.
Finally, a quick warning on secondary sterilization. We talked about how compromising the collagen properties just defeats the whole purpose of the surgery.
Exactly. You can sterilize tissue to get rid of viruses, but you risk structurally annihilating it. For instance, to kill HIV DNA, you need high doses of gamma radiation, around 3 millirads.
Right.
But Yahia and Zukor demonstrated that any dose over 2.5 millirads negatively affects the mechanical properties of the collagen. So gamma radiation is not recommended, period.
And ethylene oxide.
ETO was discontinued completely. Its toxic byproduct, ethylene chlorohydrin, was clearly linked to graft failure and severe synovitis in patients. So we don't do that anymore. We rely entirely on the meticulous testing and preservation, not post-processing sterilization.
Okay, so we have a safe, structurally sound allograft ready to go. The next critical filter is the patient. I feel like graft failure is so often just the result of putting a good graft into a bad mechanical environment.
Patient selection is 80% of the success of this procedure. We often talk about the Veltri criteria for the ideal recipient. We're looking for a skeletally mature, symptomatic patient who has failed at least 6 months of non-operative treatment.
And while the traditional cutoff is often cited as under 50 years old, you've emphasized that physiologic age is much more important than chronologic age.
Completely. We need a patient with high functional demands who has the biological capacity for healing and the resilience to stick with a really tough rehab protocol.
And the knee itself has to meet some strict criteria.
3 critical structural criteria. It must be ligamentously stable, or we have to plan to stabilize it at the same time. It must have neutral mechanical alignment, and it must have minimal, and I mean minimal, arthrosis.
That assessment of the articular cartilage degeneration is non-negotiable. We use the Outerbridge classification, which is detailed in Table 40.2, to stage the damage arthroscopically.
And this is a very strict threshold. Patients with Outerbridge grade the first, which is just cartilage softening, and grade 2, which is partial thickness fissures, less than 50% deep. Those are the patients who consistently show improved results after MAT. They still have a relatively pristine surface to protect.
But as soon as you cross that line into grade 3, full thickness fissures down to bone, or grade the 4th, exposed subchondral bone, the prognosis changes completely.
It drops off a cliff. The data from Garrett, Noyes, and Cole is clear. Outcomes become far less predictable because you're asking a new shock absorber to function on an already devastated surface.
So it's too late.
It's too late. If you see advanced grade 3 or any grade 3 with arthrosis, that patient needs something else. Probably a unicompartmental knee arthroplasty, not a meniscal transplant. Advanced arthrosis is an absolute contraindication.
Let's just list the other absolute contraindications, just to be crystal clear for anyone listening.
Okay. Advanced arthrosis, as we said, is number one. Then you have any previous infection in the joint, any systemic inflammatory arthritis like rheumatoid or psoriatic, severe neuropathy, or osteonecrosis.
And the relative contraindications, the things we can fix, but have to fix first.
Axial malalignment, so any varus or valgus asymmetry more than about 2 to 4 degrees, ligament instability. And obesity also fits in here because the increased forces just translate directly into higher graft failure rates. If we don't fix the foundation, the house is going to collapse.
Right, assuming we've cleared the patient, we move to pre-op planning, and this all hinges on sizing. The literature is almost obsessed with the 10% rule. Why is being within 10% of the native size so critical?
Because the entire point is to restore the native contact mechanics. Dienst and his colleagues gave us the cadaveric proof. If your graft is undersized, you don't adequately cover the tibial plateau. The cartilage forces might stay normal, but you concentrate excessive stress across the meniscus itself.
Which means the graft just tears prematurely.
Correct. And conversely, if the graft is oversized, too long or too wide, it overhangs the tibial plateau and acts like a big wedge, resulting in greater forces across the articular cartilage. So you accelerate the very arthritis you were trying to prevent.
You make things worse.
You make things worse. Dietz concluded that grafts have to be within 10% of the native size to reproduce intact contact mechanics. Huang's work even showed that the medial lateral width was the most sensitive measurement for predicting contact pressure differences.
So how do we achieve that precision pre-op? We've seen 3 methods evolve, starting with the traditional gold standard, plain radiographs.
Radiographs use magnification markers to try and estimate the size indirectly from the tibial plateau. Pollard's work established the parameters, measuring the distance from the tibial eminence to the metaphysis for width, and then calculating length as a percentage of the sagittal length.
But the error rate?
The average measurement error was 7.8%. Given our 10% threshold, that margin for error is it's too high for comfort.
So MRI came along as a seemingly better tool.
It was an improvement, but it wasn't perfect. Schaefer found it was slightly more accurate than X-ray. But the critical flaw, which Carpenter pointed out, is that while MRI is good for height, it consistently underestimates the AP and mediolateral dimensions because of how the native meniscus sits under load. We often ended up with grafts that were too small.
So if direct measurement of the affected side is flawed and estimation is imprecise, what's the best practice now?
The clinical pendulum has swung towards using the other knee, the contralateral knee. Prodromos and colleagues concluded that because our knee menisci are remarkably bilaterally symmetric, a direct MRI measurement of the contralateral intact meniscus provides a far more accurate template than trying to estimate size from the damaged knee.
So that's the new gold standard.
For maximum precision, particularly on the lateral side where sizing is most critical because of the higher load, the contralateral MRI is becoming the new standard, yes.
Okay, patient selected, graft size precisely. We get to the OR. The big shift in technique has been from open to arthroscopy-assisted procedures, lower morbidity, earlier rehab, and equivalent outcomes.
And the unifying principle technically is anatomic fixation. If the horns are not fixed in their exact anatomic position, the hoop stress mechanism fails. The biomechanical literature is definitive on this. Bony fixation, whether it's a plug or a bridge, provides superior load transmission and more normal biomechanics compared to a soft tissue-only fixation.
You have to resist that pull-out force.
Bony fixation is essential for that. It's non-negotiable.
So let's break down the 2 main bony fixation strategies, starting with the bone plug technique, which is typically for the medial meniscus.
Right. The medial side is amenable to plugs because the anterior and posterior horn insertions are separated by more than a centimeter. This separation minimizes the risk of the 2 bone tunnels communicating with each other and collapsing the fixation.
It also gives you a little wiggle room.
A little, maybe a millimeter or 2 for some minor rotational modification of the horn position when you're seating it.
So walk us through preparing the bone plugs on the graft itself.
The posterior bone plug is usually 6 to 8 millimeters in diameter, and we bevel it to about a 60-degree angle. This bevel is a critical surgeon's trick. It helps guide the plug into that tight tunnel, especially in the back. The anterior plug is a little bigger, 9 to 10 millimeters.
And the sutures.
We use 220 non-absorbable ethibond sutures, and they're passed retrograde from the bony end back toward the meniscal horn through each plug. If you look at a diagram like in figure 40.1, you can see how the sutures have to incorporate the strong root tissue in a whip stitch fashion before they pass through the bone plug. That's how you maximize pullout strength.
And on the tibial side, we're drilling tunnels.
Using a drill guide aimed right at the anatomic footprint of the native horns. For the posterior tunnel, we drill a 9mm tunnel right next to the tibial tubercle. This needs careful alignment. If you're doing a concurrent ACL, you have to make sure the S posterior tunnel diverges away from the planned ACL tunnel path
To avoid a collision.
to avoid tunnel communication. And sometimes you even need a limited posterior notchplasty, maybe an 8mm opening next to the PCL, just to physically allow the posterior bone plug to pass without getting hung up.
That moment when you're feeding the graft in, it's notoriously stressful.
It is crunch time. The posterior plug goes in first through a small anteromedial arthrotomy. To get it around that posterior corner, you flex the knee to about 20 degrees, apply a maximum valgus load to open up the compartment, and you pull hard on that posteromedial suture.
You use an instrument to guide it.
A blunt instrument, yes, to gently guide the plug into the tunnel. You can see this in figure 40.4. Once both plugs are seated and tamped down, the sutures are tied over an anterior bone bridge or a fixation button on the anterior tibial cortex for that definitive lock.
Okay, now let's switch to the lateral side,
Yeah.
where the fixation changes completely to the bone bridge technique. Why the mandatory shift in strategy?
It's pure anatomy. The anatomical distance between the lateral horn insertions is a centimeter or less. If you try to drill two separate bone tunnels for plugs that close together, you basically guarantee tunnel communication.
And the fixation fails.
The bone bridge between the tunnels fractures and the fixation fails. The bone bridge technique is mandatory laterally because it maintains that precise anatomic relationship between the horns within a single bony structure.
So describe the bone block preparation for this bridge.
It's a precise cut. The allograft bone block is cut to 7mm wide, 1 centimeter high, and about 35mm long. Figure 40.6 shows that template really well. We put a 0 PDS reduction suture in to help guide the block. The key is to size the tibial slot so it accepts the bone block firmly, but allows the meniscus to seat snugly right against the tibial plateau.
And preparing the tibial slot itself.
This is demanding. You create a shallow trough between the native horn remnants with a shaver and a burr. Then the final slot is created with a specialized box cutter, and it has to be parallel to the sagittal slope of the tibial plateau. Figure 40.7 demonstrates that alignment. And critically, you must not violate the posterior cortex. You do not want to be in the popliteal fossa.
So once the slot is ready, how do you get the whole bone bridge assembly in there?
The meniscus and the bone block are introduced through a small anterolateral arthrotomy. We pull the posterior reduction suture through a posterior accessory incision, and that helps guide the bone bridge into the tibial slot. It helps you maneuver it without fracturing the bone.
And final fixation.
An interference screw. It's placed on the far side of the bone block, which pushes the bridge against the near wall of the slot. You can see that in figure 40.9. That interference fit provides immense stability.
Let's talk about the inevitable pitfall. That bone bridge is pretty vulnerable during seating. What's your contingency plan if the bone fractures?
You have to anticipate it. The two most common failures are avulsion of the insertion site, where the horn attachment tears right off the bone block, or a fracture of the bone bridge itself during tamping or screw insertion.
What do you do?
If the bridge fractures, you immediately deploy a K-wire as an internal splint to stabilize the pieces. If it's non-salvageable, you have to convert your technique on the fly. Sometimes you can shape the remnants into a double plug setup and use a different anchoring technique, but in the worst case, you might have to call for a second graft. Surgical versatility is everything here.
And we should mention that while the soft tissue technique is simpler, just removing the plugs and using sutures, it just doesn't offer the load resistance needed for long-term survival.
Correct. Biomechanically, it's inferior. It's fine for securing the rim, but it's completely inadequate for the critical horn fixation that has to resist those hoop stresses. For our symptomatic high-demand patients, bony fixation is the non-negotiable standard.
As we discussed, MAT is rarely an isolated procedure. These patients often have other issues, like ligament instability or malalignment. So combining procedures is key.
You have to. An unstable knee is a contraindication for isolated MADIA. A lax knee allows for excessive motion, which puts huge shear and compressive forces on the allograft and just guarantees failure. So ACL reconstruction is the most common combined procedure.
Okay, if we're using the medial double plug technique with an ACL recon, the sequencing is key to managing that tibial tunnel real estate.
The emmet fixation, both soft tissue and osseous, has to be completely finished first. Then, when you drill the ACL tibial tunnel, it must be drilled slightly more medially than you would normally target. This deliberate divergence prevents the ACL tunnel from communicating with the Manis posterior horn tunnel. It maintains fixation for both.
And you avoid certain techniques.
We avoid any trough technique for medial ACL reconstruction in this setting because the hardware could interfere with the M.
On the lateral side, using the bone bridge technique, the surgical order is a bit different.
With the lateral bone bridge, the tibial trough is created, and the mat graft is placed and stabilized before you drill the ACL tibial tunnel. And you have to make sure that the ACL tunnel is drilled slightly distally and medially to avoid compromising that lateral tibial slot you just made. The potential for tunnel communication is extremely high in that small space, millimeter precision.
The outcome synergy seems strong, though. Graf and his colleagues reported on 8 combined metachial procedures, with a follow-up approaching 10 years. 6 of the 8 patients were extremely pleased.
That data just confirms the principle: stabilize the knee, and the allograft has a chance to survive.
The next major combined procedure addresses malalignment, MAT with a high tibial osteotomy, or HTO.
Right. Malalignment, any varus or valgus over about 2 to 4 degrees, is a huge red flag. It guarantees uneven load distribution and failure of the transplant.
Because you've overloaded the compartment.
You've overloaded the compartment. HTO is essential to neutralize that mechanical axis. And the goal isn't just to make it neutral, it's to overcorrect slightly. For a medial compartment deficiency in a varus knee, we aim to overcorrect the knee into slight valgus. We're trying to shift the load laterally.
Why the overcorrection?
It acts like a temporary brace. You want to maximize the period where the allograft and the cartilage are minimally loaded. It allows for the best healing and remodeling. We typically use an opening wedge medial osteotomy for this.
And the surgical sequence here is also critical to avoid hardware conflict.
All the soft tissue and osseous parts of the mat plugs, tunnels, peripheral repair, that has to be completely finished before you perform and fix the tibial osteotomy. The osteotomy needs to be rigid, using a stable plate and screw construct, and it has to be positioned distally enough to avoid any interference with the mat fixation hardware up in the proximal tibia. Fluoroscopy is your best friend here.
The outcome data supports this complex approach. Cameron and Saha reported 85% good results with combined math-toe. And Verdong's 10-year follow-up had very strong evidence. Patients who got an HTO with their medial mat had significantly better HSS scores compared to those who got mat alone.
It just underscores the point. If malalignment exists, HTO is a mandatory precursor to mat.
Okay, this is the most challenging section of the literature: clinical results. The studies are so heterogeneous, different outcome measures, different techniques, different patients. Synthesizing this is tough.
It requires careful reading. We have to focus on 2 things: graft survivorship and the ultimate goal, which is halting or slowing arthritis.
Short-term results, out to about 3 years, are overwhelmingly positive. Patients report significant pain reduction and functional improvement.
Yeah, Milikowski's early cohort had only 3 failures out of 22 patients at 3 years. Noyes confirmed that MET consistently provides subjective relief and increased function in that initial period. The short-term success is pretty much undisputed.
Okay, moving to the intermediate term, the 5 to 10-year window. The results are still pretty respectable. Let's talk survivorship.
Verdong's group gave us the key 10-year cumulative survival rates: 74.2% for the medial meniscus and 69.8% for the lateral. Given the high mechanical demand on the knee, those are really solid numbers for an allograft procedure.
A reliable decade of function for 3/4 of your patients.
Exactly.
But the conversation with the patient has to include the high likelihood of reoperation. McCormick's cohort of 200 patients showed that 32% needed a return to the OR at about 5 years.
And that high rate is mostly due to mechanical issues. 59% of those reoperations were for meniscal debridement, which confirms that these grafts tear.
Which ties right back to what we talked about earlier, the biological risk of remodeling.
It does. The host cell repopulation compromises the original collagen orientation, making the graft inherently more susceptible to mechanical failure than a pristine native meniscus. But despite this, the overall graft survival in that study was still 95% at 5 years.
So the graft often needs maintenance, but it stays in place and it stays functional.
For a time, yes.
The crucial question is whether that maintenance buys time for the articular cartilage. Sakia's work gave us a glimmer of hope on the lateral side.
They found no significant difference in joint space narrowing between the transplanted lateral meniscus and the contralateral non-operative side. If that finding holds up, that a properly sized and fixed lateral EMP prevents further joint space narrowing, it suggests the procedure is succeeding in its primary goal of protecting the cartilage.
But the picture gets darker when you extend the timeline past 10 years.
The long-term data is the biggest question mark. Von Lewinsky's 20-year follow-up on Milikowski's initial cases confirmed that, radiologically, there were clear signs of degenerative changes. Osteoarthritis was progressing. Even though patients often maintained good subjective function, the X-ray was undeniable.
There's a conflict between how the patient feels and what the X-ray looks like.
There is. And Haumann's group reported concerning failure rates at around 12 years, 25% medial and 50% lateral failures, with radiographs showing narrowing in 2/3 of their patients.
So this brings us back to the core philosophical and clinical challenge. Does MAT truly halt the degenerative process?
The consensus from the long-term data is it's nuanced. MAT predictably and significantly improved pain and function for a decade or more. That is a huge success for a high-demand patient who is otherwise facing a knee replacement.
But Verdonck's 10-year radiologic analysis had a really interesting caveat to that radiographic doom narrative.
Yeah, it did. They showed that while their overall failure rate was about 18%, 13 of 32 patients they evaluated showed no further progression of joint space narrowing after the transplant.
That's the silver lining.
It is. It suggests that while MAT may not reverse the initial damage, it might be effective in slowing the rate of progression. We're intervening to stabilize a previously failing joint, giving the patient substantial functional relief, but we have to be transparent that the graft, due to those remodeling risks, may not last 20 years without progressive wear.
No surgical procedure is without risk. For MAT, complication rates are reported anywhere between 10 and 50%, which reflects the complexity of these patients.
And the single most common complication is mechanical failure. It's the graft tearing. Matava's systematic review identified an 8.2% tear rate.
And these tears usually happen after the graft is integrated.
Right, which means we treat them like any native meniscal tear. You repair it if you can, or you do a partial meniscectomy if you have to. This tearing is the main reason about a quarter of patients end up back in the operating room.
What are the other complications?
Loss of graft fixation, which usually requires immediate revision. Hemarthrosis, synovitis, which we know can be triggered by those old sterilization methods. And arthrofibrosis, which is a constant concern after any major intra-articular work.
And in terms of infectious risk, what's the final word?
0 documented cases of HIV transmission in the literature from these allografts. Infection is rare. Cameron and Saha reported only 2 out of 67 knees with a wound infection, both treatable with antibiotics. The tissue bank protocols have effectively mitigated the viral risks, leaving mechanical failure as our primary concern.
Okay, let's end with the post-op rehab protocol, which is detailed in box 40.2. This is not an aggressive rehab. This is a strict meniscal repair protocol because we're protecting those peripheral suture lines and the bony integration.
Caution is the watchword, especially with axial loading and rotation. Phase 1, the immediate post-op period from week 0 to 4, is highly restrictive. Hinged brace, locked from 0 to 90 degrees of flexion. Weight bearing is strictly protected. 50% partial weight bearing with crutches.
The goals are simple.
Pain control, preventing stiffness, and getting full passive extension. That's it.
When do we start to progress?
Phase 2, from week 4 to 12, is where we gently start to challenge the knee. We progress to full weight bearing and work intensely on getting full range of motion, but we maintain strict rotational and high impact restrictions. Absolutely no pivoting, twisting, hopping, jumping, or running.
But you can do some strengthening.
Light closed chain strengthening, light leg presses, maybe 50% of body weight max.
Phase 3, from 3 to 4 months, focuses on strengthening the dynamic stabilizers, moving into open and closed chain resistance, isokinetics, addressing those quad and hamstring deficits.
And phase 4, months 4 to 6, is the beginning of return to sport activity. We introduce single leg squats, light plyometrics. Light jogging on a treadmill might start around the 4-month mark if everything is pain-free.
And phase V, 6 months and beyond, is when we move into true sport-specific drills and full plyometrics. But the ultimate return to play is criteria-based, not calendar-based.
Exactly. The big takeaway from the rehab is that this graft is fundamentally different from a native meniscus. We have to protect the bony fixation for the first 3 months, and we have to protect the peripheral repair for up to 6 months before we allow full high-impact pivoting activities. If you compromise the rehab, you compromise the decade of function you promised the patient.
Okay, to synthesize this entire deep dive, meniscal allograft transplantation is a powerful, reliable tool for a very specific symptomatic patient population.
And success is highly correlated with rigorous patient selection. Physiologically young, stable knee, well-aligned, and minimal arthrosis. Outer bridge grade 1st or 2.
And the surgical success is defined by technical precision. That means getting the best possible size match, ideally using a contralateral MRI and employing strict anatomic bony fixation. Bone plug for the medial side.
And the bone bridge technique for the narrow lateral side. Subjective results in the intermediate term are strong. We can reliably provide pain relief and functional improvement for patients who are desperate for a better quality of life. The procedure buys them time.
Which brings us right back to our core tension. Despite the strong subjective clinical results and decent survivorship numbers out to a decade, how do we definitively guarantee the long-term durability of these grafts and their efficacy in truly halting the progression of arthritis? The cellular remodeling and shrinkage we see suggests that mechanical compromise is just accumulating under the surface.
The clinical satisfaction data from Verdonk and Carter is hugely encouraging. It suggests we are effectively managing a complex pathology, but that conflicting long-term radiographic evidence, it necessitates that we keep pushing the boundaries of fixation, of sizing, and maybe even biological augmentation to see if we can convert that decade of relief into 2. The work is definitely not over.
Until next time, keep optimizing those outcomes and scrutinizing those x-rays.